we can do a Q. I, you know, I, I don't know. I mean, I hope that I wish I was more encouraged by the thought that he's a cardiothoracic surgeon. Um, and I am actually discouraged by the fact that he's a cardiothoracic surgeon
Yeah. He must be
because
80-ish himself, right?
I don't know about that.
Sure
Um,
looks old.
but I think I think that being such a specialized person, really at some point you lose sight of the high level of systems. Unless you're actually very focused on being kind of like a CEO of a hospital or on a system level, like an insurance company or
Mhm.
something. If you're just practicing medicine at that level as a highly specialized surgeon, which he is, um, you don't have really an overhead sense of what happens in the broader spectrum,
Right.
macro level. And somebody in that position should hopefully have some macro level vision. Um, in one hand, on the other hand, um, I'm just anxious about the whole idea that um, their administration in the past was keen on eliminating insurance coverage for some and canceling programs and other things. And so I'm not really sure what they're going to do
Right.
with the compensation piece. So Medi-Cal or Medicaid, as it applies to other states, in many instances was attempted to be eliminated or cut, not eliminated completely, but cut
Oh, wow.
or constricted
Hmm.
um, to 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 coverage that was available through the federal government. So I worry if they're going to continue that kind of policy, um, what's going to happen to the large
Right.
population of people who benefited from that.
And do you know anything else I'm not thinking that you necessarily should, but you hear a lot of stuff that how Medicare is going to have a lot of changes in 2025. Do you know anything about quote Medicare changes that are going to affect us personally?
I I don't know of any major changes from the patient side of things. There are some good things that are supposed to be coming. This whole negotiation of medication is supposed to improve some of the coverage for some of the medicines that now Medicare can negotiate for. I haven't seen exactly how that affects the individual patient yet, but that's in the process. Um, there is a lot of noise from the physician side of things because they are cutting some more the physician compensations. There's some proposals for cutting more of that. Other changes that I'm aware of, I don't know how big or important they are to people, but there was a lot of virtual care covered by Medicare, Medi-Cal, remote virtual kind of video visit type of stuff. A lot of that is kind of going away. Some of it is supposed to stay or being renewed in others. So there's some uncertainty on that, how much we'll be able to continue doing. I know for sure in cardiac rehab, all the abilities that we had to do any supervising virtually is going to go away at the end of the month, at the end of December.
Oh,
So unless some new program or new, and there's a law in Congress right now that they're trying to pass for cardiac rehab to try to allow it to be virtual. So instead of going through CMS for policy from through the CMS channel, they're going through Congress actually to bring this on.
well, that's novel right there, isn't it?
Um, so cardiac rehab is written into law in Congress. It's really interesting. I don't know why. I don't know the history of this, but for example, only doctors can order cardiac rehabilitation. And so people have tried to change that, and the answer is you can't because it's written on the law. It's written on Social Security law. There's a sentence that said it must be ordered by a physician. So you can't unless you go back and change the law. So I think some of the there's a couple of bills in Congress trying to change that. I don't think that one is going to pass. I think it is still important. This is now my opinion about this. It is still important that a physician evaluates the person to determine the qualification and benefit of the program. Um,
But the notion of Medicare dictating what's covered, that's not changing, right?
so that right, that has to go through CMS policy show data to them and expand coverage or care. And I don't know of any of that, but they're going for virtual. They went to CMS. CMS said no, because there's not enough clinical trial data to justify it. And so they went to Congress and they have a law, and that one is expected to pass. So there's no opposition to people expanding rehab in virtual care in Congress. There is in the medical side of things, but in Congress there appears to be no opposition. So if they pass it, they make a law that says, yeah, CMS, you have to pay for it. That's it. Then you can't go against the law.
Okay, interesting. All right, well, I'll shut up now and anybody else have any questions? We can turn that up. Anybody have a question? Brent? Yes, he is. Can you hear that? He wanted to know if Oz really was a wizard. Oh, Karen says he's really God.
Well, he's at least, yeah, no, I don't know. I know the guy. I don't know him as a surgeon or a doctor. I know of him as a TV actor or TV person, and then a politician trying to win in Pennsylvania, I think it is where he was. So that's the only way I actually know him. So whatever I say about him is very biased and non-medical. That ought to lower costs to Medicare for the drug, which should translate into lower costs to people. Haven't seen yet the multiple steps in that direction, but it's supposed to save some money to Medicare that can be used in other ways. The Advantage plans are they're different kinds, and it's tricky because depending the kind, you may get some additional benefits. Depending the kind, you may actually not have additional benefits. I am not an expert on this. I need to be very clear about this. So you may want to check everything I say from this moment on, or double check anything I say. But there are some plans. My understanding is that there's some plans that are supplemental to your Medicare. So you got all the Medicare, and then you have some supplemental components that the regular Medicare wouldn't pay. And then
right, so it's probably worthwhile looking into an open enrollment stuff for your supplemental. Are they making changes to their Advantage plan?
Now there's another way that this works. There's some advantage, and the word Advantage to me is confusing because I've seen it used in different ways. But there are some plans like the Advantage plans, who they are the primary insurer. So they're Advantage Medicare, but what it really is the Medicare has paid to an insurance company some money and say provide services to these people. And so it is the insurance deciding what coverage you get. It's not Medicare per se. It's just that the funds to pay the insurance company, it's not coming directly from you, it's coming from Medicare. So instead of you paying a full coverage to a private insurer through those programs, Medicare pays that. But the decision making of what you get is through the Advantage program. Right. And there it's kind of a hit or miss. What kind of coverage do you have that program is offering? And sometimes there's some really good perks and some really good expanded services, and in other times it's actually less than what the regular Medicare would get. And as a consumer, it's really hard to know. And I can tell you as a physician, it's also very hard to know, because I asked what was the copay for people in rehab based on the different plans. And we call every one of them, and 0 of them gave us any information. Every one of them said to us, we cannot tell you anything about what that coverage we have, because you have to tell us the policy of the individual patient so we can look at the contract for the individual patient before we can tell you anything about what we would cover. And so we got no feedback, no sense of what we could say to people, whether they're going to have a $10 copay or they're going to have a $75 copay, until the materials get submitted to them and then they send back the approvals. Then we don't know what people actually have to pay. So it's
and they do it 6 months after they started. So
well, we usually know up front because they have to pay when the copays have to be paid when people come. So we know upfront what the copay would be, but they won't tell us what their plans copays would be, because from a marketing point of view, then we would be telling people, don't buy that one because that's too expensive copay, buy this one. And so they don't want us doing that. That's my take on it. They just wouldn't give us information.
Brett.
Yeah, one more. I have a personal bias against medicines being advertised on TV.
Mhm.
And I just wanted to talk to Lopez and talk about it.
You can't hear him, right?
No.
So he says that he personally doesn't like watching medication ads on TV.
Oh God, me neither.
Everything
I
is
feel like I never left work.
all the above.
But it must be effective, right? Because there's lots of ads.
Yeah, it's people do come and ask about certain things they see on the TV. Yeah. You know, it works both ways. I actually started telling people when there are certain medicines that were new medicines that we're using, and there's a lot of people who don't want to take medicine. I'm sure half of you wouldn't want to take another medicine given the opportunity. And the other half will be asking a lot of questions about why should I take another medicine. So you know, it's an important conversation. Why should I take a medicine, and what's the medicine and whatnot? So I actually started telling people, do you actually know this medicine if you watch the news? Because it's probably in front of you every night in the news, and you see the people dancing this way and people dancing. They're all smiling like this. That's the medicine. They're all dancing and smiling.
So have you talked to any patients that started dancing in the street because of the medications that you gave them?
No, but I can tell you that you're just being honest now and serious about it. The medicine does make a difference for people. I've seen some remarkable patients that what we were giving them otherwise wasn't really making. I mean, we made some improvement and then we just stalled. We couldn't make any improvements on their symptoms. And then adding these new medicines actually allow us to improve even further. So I don't think they're right for everyone. And there's probably a little tiny bit, not too much, but a little tiny bit too much over prescribing. But I think when you're the right patient, they really do make a difference. And people do feel better. It's actually a symptomatic medication. The way in my practice, these new medicines help people's symptoms, which is actually very good because people feel it. Within a couple of weeks, 3 weeks, 4 weeks, 5 weeks, they can start telling that they actually can walk a little more, and they're less short of breath going up the stairs and things like that.
So are you talking about the SPLGT thingies?
Yeah, the SGLT2s and the GLP-1s. The GLP-1s are the ones that people are taking for that affects your weight. And a trivia question. Just a couple of days ago, I read an article saying that half of adults in America qualify for that medicine. Half. So that's 50% based on our body weights and size. So it's probably going to be in the water sooner or later. That's one version of reality. The other version is we start eating better and we start exercising more and we start walking to the grocery store and we start doing all these healthy lifestyle that would reduce a half number probably to a smaller number. And then people who, despite healthy lifestyles, still have problems with weight and are diabetes, then they're truly should benefit from these medicines. But we have a portion of the society which have lifestyle affected weight and or diabetes, and so they're probably, if it's up to the drug companies, they're half of the adult population will be taking one of their medicines.
They're still really expensive though, right?
They are expensive. Yeah, there's copays, there's expenses from the insurance side, having to pay for it, which raises cost of insurance, and then there's copays that people have to pay.
What else do you guys want to know? Golden opportunity here to pick this brain. David.
My hemoglobin is a little bit elevated. It's been running around 17 or 18. Just wondering, will that have any effect on your blood pressure? And how often should I give blood to get that to drop down?
I am not familiar with the blood pressure effect. So I haven't seen that or heard about that before. In terms of how often, I don't do that in my practice, so I don't know what the criterias are. That have your primary, have you seen a hematologist or primary talk to
No,
you?
my primary physician, he, I think said to not give blood more often than every 3 months, I think is what he said. I know that the people where I gave blood, they wanted me to give it every 2 months. And he says, no, that's way too often. So I think it was 3 months, it might have been 4 months, he told me, but anyway, he thought that that would be the first thing to try. It's nothing new, it's been this way for,
And after
5
you
or
give
6
blood, what
years.
happens to your hemoglobin?
What's that?
After you give blood, what happens to your hemoglobin? Do you know?
It drops off.
To 12 or to
Oh, I
16?
don't know. I didn't go back, since to have it tested to see how low it would be after that.
Interesting. Many people would love to have your problem.
The
Harry
the
would love to have his problem.
the reason for the 3 months is that's the time it takes to essentially replace your red blood cells. So it takes about 3 months to, the lifespan of a red blood cell is about 3 months. So if you give blood today, all the blood that you have available to in your bloodstream today, in 3 months from now, will be essentially gone, and there'll be brand new blood in there. So they may be thinking about somehow how that would be a way of stabilizing your counts. If they wanted to really, really lower your counts and keep them lower, then you probably have to do more frequent than 3 months, I would have to guess. But I don't necessarily think that people want to get you too low. They just, 17, it's high, but it doesn't sound too high to me. So I think 3 months, give it a try of 3 months sounds reasonable. Some people have to give blood once a month because their numbers are so high. I've seen that, but the magic number for any one individual patient, I'm not sure, but 3 months sounds reasonable to me.
So if you're in the position of having too much hemoglobin, that's because you have some metabolic situation where you just make more red blood cells than other people?
Right. So somehow your system is ramped up to make more red blood cells. And that on its own is not necessarily a big problem, but sometimes the blood can get thicker when you have too many red blood cells, and so there could be some complications for that. You're taking an aspirin, right?
Yes.
Yeah, that's usually the other thing we do. We give people an aspirin.
Interesting.
Actually,
But
go ahead.
no, you. I was just gonna ask anybody had any questions, so.
I'm looking for a slide. I want to actually share a slide of just something I learned recently and with people. I'm just looking for it right now, see if I can find it. Okay, here it is. But any other questions? Otherwise, I'm going to share one slide with you.
I think I have the opposite.
The other chem panel or see.
No, they have to be ordered purpose. There has to be a purpose to order it.
Yeah.
It can just come along with another panel.
Right.
I'm going to share my screen real quick. This is it's just a study that I review, and I think the information here, it's maybe valuable to some of you, as I know that you come to the program to exercise. I think it's good that you know what the latest data is on exercise. Let's see. Can you see the actual full slide? Yeah.
Yes.
So this is a review, a systematic review, where they look at all studies, or not all studies, but a large number of studies that have tested exercise as an intervention for blood pressure. And so remember that I focus a lot on the blood pressure because of its significant impact to your cardiovascular health in the future. So, and then we talked about medicines, and how, not everyone wants to take more medicine, and you should ask questions about why should I take more medicines. this is a way, exercise is one of the ways that we can reduce the need for medicines because exercise has the ability to lower your blood pressure. So this was looking at what the different kinds of exercise. So which exercise should you do? Should I walk? Should I run? Should I lift weights? Should I do this or that? And so this is kind of a review of the literature. So this is, they reviewed 270 randomized controlled trials that included about 15,000 participants. So the one thing to realize, 200, if you divide 15,000 by 270, some of these studies were small. And that's usually a problem when these, there's not like 10,000 patients in a single study or 5,000 patients in a single study, which is what we usually do for a new drug, for example. So a lot of these studies are small. So that's important to recognize, one of the concerns always. But it's still a remarkable large number of studies and a remarkable large number of patients. And so here's, so the graph on the left is the systolic blood pressure. The graph on the right is the diastolic blood pressure. And then the graph zeros on the top and negative numbers, that's the reduction of the blood pressure. So from your initial blood pressure, how much lower it was after the exercise intervention. So -4 points here corresponds to this one here, which is HIIT. So HIIT is this high intensity interval training. So your Peloton bicycles were where you just pedal a little bit and suddenly you pedal really fast. And then you, for a minute or two, and then you slow down again and you speed up again. So that's HIIT. So that had about -4, and it was the worst of all because everything else gets better as the arrow, the yellow arrow points out to lower the blood pressure. Then you have aerobic exercise, which is your traditional walking, running kind of stuff. It could include an elliptical or a bicycle just to aerobic exercise. Then you have the next thing is this dynamic resistant exercise. So this is when you do weightlifting and machines, bars and stuff, where you're actually generating force. So there's a little bit of this isometric contraction, but then you're actually able to move something. So you actually lift the weights or move the bars or the loading. And so all three of those are fairly same. So you can do one or any of the others if you just want about -4 points of reduction. If you want a little more, -6 or closer to 6, then you combine the two. And this is what the American Heart Association recommends, that you combine aerobic up to 150 minutes at the minimum, and with resistant exercise at least twice a week for 60 minutes. So 2 times a week where you do about 30 minutes of resistance exercise or a dynamic resistance training, or you can do like 3 times a week for 20 minutes or something like that. So if you combine those two, which again is the American Heart Association recommendations, you get about a -6. But then you get down here to this one over here, which is the isometric exercise training. And this has actually been kind of interesting to me and surprising. It got the best reduction in blood pressure. So that's a -8. That's almost twice as much as all these other ones over here, and just about 40–50% better than what's recommended by the American Heart Association. And so if you look at this cartoon here, it's the weights, but the weights without you, where you pull on the weights, or the weights are, you're holding the weights, but you're not actually moving. So it's really isometric, meaning you don't move through space training. So you're creating the contraction, you're pushing something, you're lifting something, you're holding against something, but you're not quite moving. You can do it with machines as well. You can, again, work against resistance without that much movement. Or you can do what I like the most, because you don't need any equipment. You don't need anything. You can do this anywhere in the world that you have a wall. So this is a wall squat.
Dave Clark loves the wall sit. I personally know that.
And so you can actually build the exercise program just around wall squats. And that would have the largest effect of blood pressure. Now, I want to recommend that you only do wall squats for your exercise program. what I currently recommend is that you do the walking and or the bicycle and or the elliptical, and then you combine that with the wall squat as part of your resistance combined training. Now you can do a little bit of weights as well. Weights don't hurt you. They're actually helpful. So it's some variation of that, but for sure I would include something isometric like a wall squat with your walking at the very least, and then add some bands, some weights, or some other type of resistant exercise. Where
So
there's
did this article offer guidelines that you should do it daily, twice a week, once a week, 3 times a week, X number of minutes or anything like that?
So this is actually without knowing what I'm going to say now, but there's probably at least 270 opinions on how to do this.
Uh-huh.
Each study actually, this is again, it's one of the issues when you do these meta-analysis or these reviews, that they probably, every study probably did some variation of it. But if you lever the recommendations from the American Heart Association, which are well seated on not only data but expert opinion, at least 3 times a week, you should do some wall squats at least 3 times a week. If your body tolerates it and you feel great about it, you can do probably more, but at least 3 times a week. You would do, and what I recommend people is first find out how much can you tolerate a wall squat, because some people can only tolerate 5 seconds, 10 seconds of it. You need to make sure that you don't have back pain and hip pain or knee pain or ankle pain that may actually make you fall down or hurt more. So there's some orthopedic considerations here. But assuming that you don't have joint and back pain that gets aggravated by this, you just figure out how long can you do your first wall squat. And that may just be 10 seconds, and that's okay. And so you learn to go down to the wall squat position. You come up after your 10 seconds, you do that 3 times with 1 minute of rest in between. So it's three wall squats, 1 minute of rest. And you start from 10 seconds and you just start building slowly from that. And then you want to try to aim for anywhere between 30 seconds to a minute. And so if you get to 1 minute on the wall, 1 minute off the wall, 1 minute on the wall, 1 minute off the wall, 1 minute on the wall, 1 minute off the wall, that's probably a total of about 7.5 minutes of exercise, maybe 8 minutes total. You got your set done. And then you want to do 3 of those sets, and you do that 3 times a week. So that gets you your 20 minutes 3 times a week that the American Heart Association, because 3 sets of 1 minute wall squats, 3 reps, 3 sets, it's about 20 minutes of exercise. And so that's how you clock in your time for what the American Heart Association recommends. But most of us can't start at 1 minute on, 1 minute off. Try it, you'll see. You start getting burning on the muscles, and you start getting some trembling and some shaking of the legs, and that's your body telling you, get me off the wall. And you do, and you get yourself off the wall. But you start with whatever you can tolerate without overdoing it. And then you just, every week or 2 weeks, you add a couple of extra seconds, of 5 seconds, 10 seconds more as you tolerate. And over time meaning months here, your body slowly will build muscle mass and some strength, and you'll be able to tolerate better.
Well, thanks for sharing that. The tragedy here is we don't have very many walls.
You don't have any walls.
But we do the wall sit in many of our circuits.
Yeah. Good. So anyway, so that's what I'm prescribing now.
Yeah, good for you. Good for you.
People, because it's low cost and very, very effective.
And I will share in my Monday Zoom session, we actually do a 2-minute wall sit. Because I'm home and I have a wall.
Yeah. Can everyone do a 2-minute wall sit?
Some of them can. I bet you Dave can.
No.
But
So
you try,
how-
right? You do part of it.
Yes, I do.
Yeah.
Yeah. Quite a bit
So-
of it. Yeah.
Talk some more with Linda. Linda, can you come up with some plans to actually have them build up on that?
Sure.
Like every 2 weeks or something, go up a little, like 10% or 15% of the time they can do. And maybe every 4 or 6 weeks, take a break or something.
Dr. Lopez.
And then see if 6 months from now, you've got a better wall sit time.
Yeah.
There's a lot of hallway with open walls.
Okay. So I should do my circuit classes in the hall?
So here's the other safety comment I want to make. So if you actually take this in serious and you start doing this, your blood pressure may actually come down. And so if that happens, you may start feeling dizzy and lightheaded, and you shouldn't just cut the exercise. You should talk to your doctor about cutting your medicine if possible. And if you're just taking the medicine for blood pressure, it's the only reason you're taking it, for sure your medicines can be cut and you can continue exercising. That would be preferred. Lots of you take medicine for other reasons in addition to the blood pressure. And so it's a little more complicated conversation. If you have heart failure, or you have a heart attack before, or if you have diabetes and we're doing kidney protection with the medicines. And so there are lots of other reasons other than just blood pressure for which you would take a blood pressure medicine. So not everyone can simply just stop the medicine. So don't do that on your own. But if you start seeing your blood pressures are coming down, you're getting a little lightheaded with your medicine, that's a good reason to do a visit with your doctor, explain what you've been doing, and then say, hey, that doctor at the program, I don't remember his name, but he said that maybe you can cut my medicine. And then don't tell them my name, even if you remember. But do that. Do ask them to consider the reduction of your medicine. And again, if it's just for blood pressure, that's a very reasonable request. And we do it all the time. It gets trickier or harder to do if it's for other reasons.
That has happened in here for sure.
Yeah.
Dodie.
On a personal note, Dr. Rogers is at church where I go to church. And he promised me that he was going to come to you and talk to you about a subject that he might come here and talk to us about. So if you see him, you might remind him.
That's Jason Rogers?
Yeah.
Okay.
He was
All right.
interested, but anyway, he said he needs to talk to you about what he could come talk about.
Excellent. Next time I see him, I'm going to hit him for it.
Good.
Do you ever see him?
Not that often. He's always in the hospital and I spend most of my time in the clinic. So, but every so often him and I cross paths in the clinic.
Yeah.
So
And how about Jeff Southard? Do you ever see him?
I see him a little more than I see Jason Rogers.
I'm going to encourage you to bug him too.
To come and talk?
Yeah.
Okay.
He's done it before, actually. Not
Okay.
recently.
Yeah. Do you remember what he talked about, or?
He talked about interventions.
Okay. Yeah. Well, Jason Rogers is a phenomenal structural heart cardiologist. There's very few of them out there as good as Dr. Rogers.
Yeah.
So he can talk about some amazing stuff that they do with clips and other things. They plug holes in the heart of people that before they had to go to open heart surgery. And it's really amazing the techniques that they have. They can go in through the veins and arteries, find the hole with amazing imaging techniques, and then put little plugs in there, plug holes that are usually not good for people, without people ever having to go to surgery. And then they do the same thing with these clips for the different valves that are leaky, for leaky valves. And the data on that is expanding. The American Heart Association meetings just happened this past weekend, and there were more data continue to support how patients do fairly well with those clips. So we're going to see more and more of those clips being used, people with leaky valves.
Interesting.
So they work, and they UC Davis interventionalism among them, Dr. Rogers, have worked in the leading development of those clips. So
All right. Well,
But
maybe yes,
I had a question about the clips. Can the clips be used on artificial valves though?
oh, that's a great question. Artificial mean like you had like a TAVR?
Like you had a valve replacement. I have no
Valve
idea.
replacement.
Yeah.
Like a surgical, like a surgeon replace your valve, and now the
Yeah.
valve.
Yes. But it's not working well. It has a leak. He's told me it's got a leak, and he hasn't given me any. You're the first person that's giving me any idea that it could be fixed some way.
Inappropriate shock was I was lifting heavy groceries and
Mhm.
walking along the aisle, and mid-step it hit me. Then the same thing happened like 3 months later. I think they reset it a little bit, but a year later, I started having to get these cardioversions. And I was thinking, okay, instead of, before I go to the emergency room again and again and again, maybe I should just go to Winco and lift some more heavy groceries. And
So when you say cardioversion, you mean that your pacer is trying to pace you out of
no,
whatever?
no, I actually went to the hospital.
Oh, I see. Got it.
I'm
that-
actually unconscious pretty much when they're doing whatever they do.
Yeah, yeah. No, I understand. So that's for atrial fibrillation?
Yes.
Got it. Got it. Okay. First of all, thank you for sharing your personal story, and hopefully that's okay that we talk in public like this. Do you mind if I ask you, where do you go for your health care?
UC Davis Health for most of it.
So have you talked to your cardiologist about an ablation for your atrial fibrillation?
I did eventually get the ablation. It took a while, but I'm concerned that it may come back. The atrial fibrillation may come back.
Sorry, the screen froze and I didn't hear what you said.
So I'm concerned what happens if the atrial fibrillation comes back. It seems more efficient. Let's just try to self-cardiovert, then go to the emergency room.
No, I understand that. My
Yeah.
question was, did you discuss doing an ablation?
Oh,
which
I
is
did have an
different from a
ablation.
cardioversion.
Oh, it took a while. It was 6 months later that I got the ablation.
Okay. And have you had a problem since you had the ablation?
I suspect that it may be coming back. I can't quite tell yet if the fibrillation is coming back.
Yeah, so you're in a journey, in this journey of atrial fibrillation, making you, symptomatic and bothering you in your life, which is what I hear you saying. Because your defibrillator is going inappropriately because of atrial fibrillation. That's one of the things atrial fib does. It tricks everyone on many things, and one of them is trick your pacemaker and or your defibrillator. So having an ablation is probably the best approach to try to manage that. The issue with ablations is that they don't always work on the first one. And so, in fact, when I counsel people, I tell them they psychologically should be prepared to go up to 3 times to have an ablation. Because, and we're getting better at this, and the numbers are better, the techniques are better, our operators are better every day. But the first ablation, in the old days, it was only about 60% efficient or effective. So it took a second one that will get you up to about 70%, and will take you a third one that will get you up to about 80% effective. So that means about 20% of people who had 3 ablations still had AFib. Today, we're much better. We're probably on the 70% at the initial, about 80 to 85% on the second one, and about 95% on the third one. So those are much better odds that we can get rid of the atrial fib, but you got to be prepared. It's a journey. And so it takes about 6 to 12 months to know whether the first one worked or not. And so if you're about 6 months after the first one, you're still in that time where you could have atrial fib, but that doesn't mean the first one didn't work. So it's a journey. It's a complicated conversation where I'm going with this between you and your doctor about where you are in that journey and whether the next step of the journey should be another ablation or another cardioversion. I wouldn't recommend that you just lift bags at the grocery store. Take care of yourself. That is not what I would recommend.
Okay, thank you.
Thank you for the question. That's actually was a very good and thoughtful question. Atrial fib is a pest. This is everywhere. Yes, it's tough to take care of.
Any other questions?
Well, then
Nope.
thank you, everyone. My apologies again for being delayed, but it was fun, like as usual. So thank you for the time. And
Very
Thank
informative.
you.
Thank you.
have a happy Thanksgiving, everyone.
Yeah, happy holidays.
Take care.
Thank you.
Thank you, Dr. Lopez. Bye, everyone. Interesting. Yeah, I saw that. That is interesting.
Who gets the sleep observer?
Liliana, I'll take it.
Okay, here's a. I was giving.
All right.